Okay, we've got 245 people on the chat. Thank you for joining us at 2 o'clock on a Tuesday afternoon. And I'm delighted to say we're once again joined by Dr. Matt Butler. And I've asked Matt to come in because we've all been challenged with reopening our schools, and we're all at different points in that journey across the country. However, we did have a report on Tuesday afternoon where it was publicised that the R rate across the country was going up. And I know that's made some schools go and rethink about what they want to do next in terms of the staged and planned reopening of schools. So twofold really. I want Matt to go and talk to us about the R rate, because it's something we've been trying to get our heads around over the last 72 hours in our schools, and also about track and trace, or test, track and trace, and just go and talk about that, because they're the two things that are causing school leaders anxiety in terms of planning a reopening and admitting more pupils. So Matt, I'm just going to see if your microphone's working, and just go welcome. I don't think the video's working, Matt. Yeah, now Matt, you're in the hospital.
It's not working because we don't have any webcams in the hospital.
Oh right, well, we can hear you loud and clear, Matt. So you're coming across crystal clear on the video. So sorry, can't hear you. But
you don't
welcome,
need to
Matt.
see me anyway, Simon.
And thank you for
it's
taking
not a pretty sight.
A bit of time out of your busy schedule for us. And I just want to introduce Dan Thomas, who's my co-chair today. Dan, could you just say hello and go and introduce just tell people who've not been on one before how the Coronacasts work?
Yeah, good afternoon, everybody. If we are currently recording this session, so if you don't want anybody to see your faces, just turn your webcams off. If you've got questions, there is a chat function that you can use at the bottom of your screen. Please use that. Please don't open up your microphones. If Simon's going to bring you in to ask a question or anything, he'll let you know, so you can open them then. Otherwise, just keep them closed. That's it, I think.
Thanks. And then Ray's going to curate the questions. So if you put your questions in the chat, not Ray, sorry, it's Ruth. Ruth's going to do that for us. So Ruth's going to look at the questions and go and curate them at the end as well, or go and ask Matt them. But I'm going to start off with a few general questions of Matt before we start. So Matt, before we go into the R rate, have there been any developments that we spoke to you about 2 weeks ago? Any new learning around the virus? I mean, particularly, I know that we've been waiting for the antibody test as something that we feel would make a big difference to our working lives. So could you just give us a quick update of any new learning that's happened in the sector over the last couple of weeks?
Yeah, so hi everyone. Specifically on the antibody test, there has been a lot of obviously interest in doing what we call zero surveys, which is where you randomly select, the ONS are doing 17,000 people over 7,000 families, to check to see whereabouts the virus is currently, and where it's sort of been. So they do swab tests as well as antibody tests. The difficulty with the antibody test is obviously having antibodies might not necessarily tell you whether you've got immunity, because at the moment we don't know whether they're what's called neutralizing antibodies. To do those sorts of tests are quite involved. Involve live virus cultures, which are obviously fairly challenging when you've got a virus that can have lethal consequences. So, but having past infection likely means that even if you were to get it again, you're less likely to get severe disease, and that's how original cold viruses are felt to have started. So one of the four coronaviruses that causes the common cold was believed to have caused a COVID-like illness in the 1890s and caused many, possibly millions of deaths. And now we see that every day, and people can get the common cold sort of once or twice a year. So antibody tests are coming in. We still haven't had them deployed within the NHS yet, but they are available for people to use over the counter. I think you can get them from Superdrug. So one of the other difficulties with antibody tests is, bizarrely, as the seroprevalence, so as the number of people is quite low. So I think it's the range in the UK is around about 6% of the population, according to the last ONS survey, has had the virus. Bizarrely, if you have such a low seroprevalence, having a false positive actually becomes more of a problem. So even with very good tests, with what we call the specificity, even if the specificity is very high, if the disease is not so common, then that might tell, even if you get a positive, it might mean, even if it's positive, that you're 50-50 as to whether you've had it or not. So we're starting to understand that a bit more as well, and we'll only get more information as we test more and more people. So that's on the antibody front. I think the biggest change, and it's one that we first talked about in the initial Coronacast, is around face masks or face coverings. So the coverings being things that you wear that are hopefully a cotton blend or two fabric layer blend of face covering to then protect others from respiratory droplets or aerosols that you might expel if you had coronavirus, COVID-19, but weren't aware of it because you didn't have symptoms. Germany has come out and actually said that there is now evidence for that, for wearing face coverings in public all the time. And this is something we talked about right at the very beginning, that the countries that seem to fare the best have been countries like South Korea, Malaysia, whereby masks, because they were hit by the original SARS and MERS, that masks in public have been widespread for a long time, and obviously become heightened in a pandemic. Whereas because culturally it's never really been done here in the UK, it's a very slow process to get that instigated. So hopefully more and more information will come out about masks. The difficulty with doing any evidence base for masks is that it's like parachutes. It's very difficult to sort of do a study because you're potentially exposing people to a virus that could have harmful consequences. So there aren't any trials of parachutes working for that, for the reason it's just common sense. And to me, it's always made common sense that masks prevent transmission, and therefore when we get on to talk about risk and higher risk staff groups, masks within schools may be something that you think about, particularly when one of the questions was around staff members moving between bubbles. I think in a low risk, low prevalence setting, that's probably doable, but I probably would heighten measures such as ensuring really good hand hygiene, trying to lengthen the period in between staff moving between, so maybe leave it sort of 48, 72 hours before that, so that any contamination they have or contamination on their clothes, if they decide to wear the same clothes, doesn't cross over. But also whether those staff should wear face coverings would also be important to think about. But apart from that, there haven't been any major, apart from all the figures. I mean, we've only had one case in the last 3 days here at Addenbrooke. So the virus really is at the moment very well controlled in the community. And obviously schools only opened 9 days ago, so it would take 2 weeks. So we'd only really know on the 14th if any effect of schools has occurred. But obviously things were starting to relax before the 1st of June in other areas, so we were allowed to meet outside, and those things don't seem to have affected transmission to any great degree.
Thanks, Matt. It's really helpful. And I think if any colleagues have got experience of using face masks, I know my friend Steve Alice is planning on doing it with some of his year group when he returns. So if anybody's got any experience, we'd love to hear from you about the practicalities of wearing face coverings. I keep saying face masks, face coverings within school settings. Matt, just one more thing before we go on to the R rate. In terms of the transmission from children to adults, you shared with us the study from New South Wales, where it was looking like in that very small study that there wasn't a high degree of spread from children to adults. Any further information on that?
Yeah, so we definitely have had more cases in secondary schools where a single pupil, particularly because pupils in their sort of teenage years are perhaps less willing. Firstly, they have fewer symptoms, but also they tend to not follow rules as readily. Certainly cases where sort of single students have infected large numbers of people, including teachers, but no further studies or outbreaks that I've managed to find in primary settings, which is very reassuring.
Okay, that's globally, is it, Matt? You're talking.
Yeah. So mainly European data, because bearing in mind lots of schools never closed down. in sort of Asian countries. So places like South Korea, they were going to school throughout all of the pandemic, and at one point South Korea had the largest number of cases outside of mainland China at that point. Now, obviously, we're in a much worse state still, although we've got a much lower case. We've come from such a higher peak. So there is always the caveat that we really don't know in a higher prevalent setting. Obviously, the more prevalent it is in the community, even if at the moment it's a lot lower, we're still talking about how we were back on at the end of March. So we're getting the same number of cases that we were at the end of March now. It's just taken us a long time to get here. And what we don't know is how that higher level of community prevalence is potentially going to spill over into schools, but certainly there isn't any great evidence for that. There seems to be more and more mounting evidence that children have a lower susceptibility, so they're probably half as likely to get it in the first place. And because of all the other reasons that we've talked about, that they're then less likely probably to spread it back up to adults. But and because they get, we sort of we're getting more evidence that even if you're asymptomatic, your transmission window, so the period at which you are infective, is shorter than say if you're symptomatic. So the very severe cases remain able to transmit infection up to 3 weeks. Whereas if you are asymptomatic, your window for transmitting is obviously is going to be a lot less. So maybe a matter of days, or maybe even only a day. So the potential there is reduced.
Okay, that's great. So let's move on to the R rates. There's lots of confusion around the R rates. We've had the Cambridge University study, which went and said that all regions were actually, the 7 regions were increasing. A lot of colleagues on the call today are from the Northwest, and the Northwest median went to 1.01, but the confidence interval, of course, straddled 1 within that data. So it caused quite a few schools to evaluate their plans for reopening. But we've also heard that things like, well, the London School of Hygiene and Tropical Medicine has said that the Northwest value is only 0.8, and then we've had Matt Hancock saying that it was below 1 in all regions. So can you we're really struggling with this as educators, and where we're trying to evaluate risk around reopening. So can you help us in your very articulate way to understand the R rate a little bit more?
Yeah. So I mean, when the R rate was first mentioned on the Downing Street press briefing, I was a little bit surprised at how the government was seemingly wanting to get the understanding of what the R rate was to the general public, because it is a single measure of the rate of spread of a disease, and it's dependent on so many other things that it's to distill what is quite a complex disease down to a single number is always going to fail, because as soon as you get understanding, then unfortunately you then can get misunderstanding, because you think that the R rate is therefore the be all and end all for reducing transmission, which it is in a large extent. But unfortunately, if you focus down to a single number, what you then forget is what actually are the things that are feeding into that. So one analogy would be, so if you've got, just thinking about, say, your end of year school exam results, if you've got a school with very few pupils, and if you imagine the few pupils being fewer cases, which we're experiencing now, so a smaller school is much more likely to have variability in its exam results year on year compared to a much larger school. So if you are a 1,000 pupil school, but your pupils from one year to the next do half as well as the previous year, then that is obviously a big cause for concern, because the average is much harder to shift in a bigger school than, say, if you've got, say, maybe a very small rural setting where you've maybe only got 15 pupils. It only takes 3 or 4 of those pupils to underperform for that to shift your whole results. And we're in the same position with the R rate. As the numbers come down, the variability of R is going to become wider, and therefore focusing on whether it's above 1 or below 1 is meaningless, because the other reason that R at the moment doesn't really help schools in any great way, shape or form is that schools aren't impacting on the R rate. the increase in the R rate in the northwest, by what I've just said earlier, we only reopened schools on the or to a large extent on the 1st of June. So and also it is not schools, because schools haven't opened, where your R rate has increased, that has led that. What will be driving, and what I said on the second Coronacast, what is driving increases in R rates is local outbreaks in care homes and also local outbreaks in hospitals, to a large part. And if you go back to the school exam result analogy, if you've only got if you get down to a position where regionally you only have 50 cases, and then a large care home, one asymptomatic member of staff manages to infect 10 other people, then you may get a spike in cases locally, but that will cause R to go above 1. But it's in a singular setting, and what we do know more about this virus is that it seems to spread. In some people, they seem to spread it to a wide number of people, whereas the vast majority of people who get it don't tend to pass it on at all. I would really encourage you not to focus on R, particularly in now that we're getting fewer and fewer cases. The thing that you need to focus on is difficult because you don't have that data. What you need is local data, almost by postcode, to say how many cases, what is the prevalence of infection. Because if you've got no cases, or if you've got no cases in your postcode or your postcodes that feed into your school, then that is very reassuring. If you then get one case, your R has gone up above 1 because someone's brought it in from other postcode areas. But having one case in a school feeding area is not going to be that concerning. Your R would go above 1, but it wouldn't necessarily mean that you would want to do anything differently in schools. You'd want to know where that case potentially was and heighten your measures of surveillance and awareness within staff, because this is going to go on for a long time. But I certainly wouldn't use R as a measure of judging whether schools should open. The reason that there's differences is that, remember, R is not something that we go out with clipboards, look at all the cases, and then say R is this. R is a future projection. It's almost like forecasting the weather. So R is a future projection for what the infectivity rate is at that point in time, or it is a measure of what your R rate was 2 weeks ago. So neither is really going to be helpful for what you need to do now.
Okay, that's really helpful. Just picking up a couple of our things on the chat. So I mean, at the moment, that postcode information is not available. The only granular data I've seen for my local authorities around the hospital deaths, which are going down. So, but there's nothing. There's no more granular data than that, than just the whole of the northwest.
Mm.
Yeah. So I've also
and that needs to be made available. I think that the plan is to make it available. It's how soon that can happen. Whether or not it's going to be made available to individual school leaders, I'm not sure. But local public health leaders should certainly start to receive that data, hopefully in the next few weeks.
Yeah, and what's been really unhelpful, Matt, actually in the northwest, is that some local public health officials, like the one from Cheshire, Cheshire West, went and said it was inconclusive. But then we've had a very firm stance around the R rate from the person for Greater Manchester, saying that schools shouldn't open yet. So there's been a real variability in the advice we've had from public health officials based on the R rate of 1.01. So it is hard.
And the surer someone is about something, I would always take it with a pinch of salt. Like I've always said, that there are lots of uncertainties. So that in this, and there are no definites. You can only ever base what we do, and what I was talking more about when I was speaking to the NAHT is more about risk, and risk is the key here. So your risk in the northwest is much lower than it was a week ago when everyone else opened. And that's because the prevalence has gone down dramatically, and it's going down in every region. So the number of cases that are in the area is going down everywhere. Now, as I've said, the fewer cases will cause greater variability in R, which makes R less of a. R was important at the peak because what you want to make sure is that you go over the peak, and that you can only ever go over the peak, over the top. If you imagine skiing down a slope, you can only do that once you get R at 1 or below 1. So it's important to sort of get rid of to stop the pandemic worsening. But once you get into the maintenance phase, or this sort of never-ending period of gloom and disaster, which we're going to be in for some time, you can't use R to any meaningful way to make sort of rational decisions, and even if you've got local data, local R is going to be very tricky, because if your R spikes and you've had 0 cases locally, then by definition it's not your region that's been the problem. It's because someone's travelled out of your region and brought the virus back in. So it would have always been someone else's R rate that would have been the important thing anyway.
Yeah, got a question from Louise saying apparently there were 4,500 cases in Northwest. I thought there was only just over 1,000 nationally yesterday, Matt. Am I right on that?
So one will be the incidence and one will be the prevalence. So
okay,
so nationally we have around 5,000 cases a day, but I don't know what figures they're referring to. It sounds entirely plausible that you'd have. I mean, the Northwest is a fairly populous region. It sounds. I think effectively, if you looked at your population as a whole, you'd expect maybe 0.5% or lower to have active infection, or maybe even lower than that. I haven't seen your local prevalence data, but incidence is different. So prevalence total cases that are there, which may or may not be infectious. That just means how many swabs you've had positive in the last couple of weeks. But incidence every day we're expecting at the moment to have about 5,000. By next week we'll probably only have 3,000 a day, or maybe even lower. The week previous to this week was 8,000.
Okay. So let's move on to track and trace. So another thing that's caused anxiety is that in terms of the 5 tests, that track and trace isn't fully effective at the moment. So I've heard all different reports saying it won't be effective till September. It won't be effective till the end of June. So what you advise to school leaders in terms of test, track and trace, and the anxiety about opening when that isn't fully in place?
Yeah, so no track and trace system can ever reach 100% of contact tracing. In order to be effective, I put something around about schools opening over the weekend, whereby you only need to get up to 40% of contacts traced in order to be effective. Obviously, it's better to get 80%, but they showed that you likely would avert a second peak if you could at least track and trace and isolate 40% of contacts. The key thing with this is going to be speed at which people can firstly get tested and then input data into the national system. The national system is working, as in most of what you hear from people saying that there's lots of tracers laying idle. That's because they didn't realise that now that we've had 3 months of lockdown, lots of people in the population are very tech savvy, or if they weren't beforehand, they've now become tech savvy. So a lot of people are using the online self-service portal to effectively do all the contact tracing themselves and input people's details and things like that. So there is a system up and running at the moment. They haven't actually said at all how many. I watched the Health Select Committee towards the end of last week, and it had only been in operation for 6 days, but they, because of all the difficulty with the Statistics Authority, they're very reluctant to release any data until it's had it all been polished and ready. So I haven't seen any data from Track and Trace about how many people they've called, how many of their contacts they've managed to see. So I don't think we can make any judgments as yet. Certainly, there won't be a system that could deal with. I think what the September thing is to deal with the second peak, whereas actually at the moment we're in this a bit of a twilight phase whereby track and trace and isolate is becoming more important as the case numbers go down. But as the case numbers go down, the number of cases that they'll have to deal with also goes down. So the number of cases that they may not be able to track and trace now isn't necessarily indicative of that they won't be able to in the future. And I think by September, that's when that figure comes, that actually that's when you need a fully operating track and trace system, because it's not like by the 1st of June we needed a track and trace system. It's something that becomes more effective as your prevalence goes down.
Okay. Good, that's really clear, Matt. Thank you very much for that. Got a question from Judy, who's asked about, you told us a few weeks ago that they didn't test under 5s routinely, and then I also heard Matt Hancock said they were going to start testing under 5s.
Yeah,
so what's the reality behind that statement?
I think the reality is that firstly, you won't know that they've had it. And so none of the under 5s will get tested. Secondly, like I've said, you try test it. I mean, I wouldn't want to put a swab down my kid's nose. I think I know what he would do to me after I'd done it. I mean, if a child has symptoms, it would be useful to see if they could get tested for obviously local cases. But I think if once we look back on all of this, the under 5s are going to be still a black hole of data. We're not going to have huge numbers tested, even though now we could test them. Because firstly, they're not going to get symptoms. The parents are not going to want to drive sort of 10 miles, whatever, to a testing centre, because they're going to probably have passed it on to them, and themselves are going to feel well. And so I think it's, although I would encourage you as teachers, if you identify a case either through fever or new cough, or new loss of taste or smell, if you identify those symptoms, then I would certainly encourage the parent to get them tested, and I think that would improve uptake, because obviously that you would be your advice would be held in high regard from the parent's perspective. But I think that they're not going to report necessarily loss of taste or smell. They don't get much of a fever, and they rarely get a cough. And if it is a cough, if my daughter did in fact have it when I think I had it, she only had a cough for maybe an hour or two, and that could be anything. When they're so young, could have been a bit of hay fever or something. So I don't think many people are going to get tested in that age group.
Okay, that's helpful. Okay, and I know some local authorities have said that if children are symptomatic, then they've given them the permission to close down that bubble if a test can't actually happen, and schools will make their own individual decision on that. So that's okay, Ruth. So how's the questions looking, Ruth? Are they diverse, or can you manage to group them?
Yeah, there are quite a lot around the R rate, which Matt's already answered, and just some questions on why the different numbers in different parts of the country, and lots of people asking, do we know what the lag is on the data, and is there a way of us getting hold of more reliable and more localized data? A couple of people have mentioned postcode specific, because obviously the Northwest is a very big region. Is there any chance, and if we can't get hold of that data, do we know when that's likely to be?
So the problem with the further you go down locally, your number of cases will go down, and therefore the reliability of any conclusions you make from that data will also be less good. So the models that they've produced for the regions are based on fairly robust data taken from sort of Public Health England labs, as well as sort of ONS Sero survey data. The difficulty with going down to a school level is that that's when you need to move away from R, and you need to just think, well, how many cases have I had locally in the last 2 weeks? And if it was 10 over the last 2 weeks, and then in the next 2 weeks it's 5, then that's reassuring. If it goes from 10 to 30, obviously you've got a mini outbreak, and you want to be a bit more vigilant and know where those cases are. However, as I've said, if it goes from 10 to 30 and it's all located in a single care home, which is locked down, and no one's visiting, and you're the parents of your children who may have grandparents in those facilities, if they're not visiting them, then it's not going to affect schools. So really knowing where the cases are is the key. And that data would be available to your local public health chiefs. Obviously, there comes a degree of confidentiality here, so they wouldn't normally release public health data to everyone, because if you know that it's in a postcode, you might only have one care home in a postcode. that care home might only have 15 residents, and then you could infer who potentially has infection. So patient confidentiality does to some extent come to play here. So there will never be complete openness of where the cases are, unlike they have in South Korea, where you can look on a phone and you can say, you can go back in time and see when your phone pinged to a potential case, and the age of that person and the gender of that person to see if you think you might have been a potential contact. I don't think in this country it would get to be that granular of data.
Yeah.
That's something, Matt. We've been recommended that we stick to class size of 15 in our primary schools, and we've also I think the 2 metre social distancing in the schools has very much been relaxed for primary schools in the government's preventative measures document. However, if the government were to then go and say, well, we want you going back to classes of 30 in September, what would your view on that be? That's Dave Waring and Steve
I'm sure that
question.
if that happens, it would have to be a Wales model where you have rotas. Unless you've all got oodles of cash that you've been sitting on that you haven't been telling us all about. I don't think so, because we haven't really been able to sort of fund schools adequately, unless they suddenly funded massive expansion in school buildings, or you had lots of temporary facilities. But we're talking about September, so it's not going to be that long until you get into winter, and you're not going to want huge numbers outside at that point. As I said before, this all that you do now is going to be a dress rehearsal for winter, and winter time. If you look at when the peak, if there is going to be a second peak, say if track and trace completely fails, then the second peak will be in December, and therefore you need to think, well, how am I going to have a full school back in December? Where am I going to put them all? I mean, obviously, it's just you're not going to be having assemblies and using the hall for sports and things like that. So, can all your halls be repurposed to put classrooms in there? Maybe 2 or 3, depending on the size of the hall, with screens in between. Obviously, that's difficult because then you've got noise from all the different children travelling. But certainly,
I mean, lack of teachers as well.
Yeah. Do you think the rule will be relaxed then? Lots of people asking about social distancing rules being relaxed in order to meet that, to be able to actually physically get children into school. Is that something you foresee will happen?
I mean, if say we had a very good track and trace and isolate system with lots of people being tested that don't necessarily have disease, so we start to just do more screening, then potentially social distancing could be relaxed even further. Obviously, we are going to get to a point at some point whereby we're going to go back to normal, because this thing will just turn eventually, either we'll have a vaccine or it'll just turn eventually into the common cold. Now, when that happens is going to only be borne out by when we get there, but and it's probably not going to be for a few years, certainly on the latter front of when it will just peter out. But the vaccine may come in towards the end of this year, and then there may be a strategy that they could put in place whereby enough people get vaccinated in order to allow sort of lessening of social distancing, or that the cases just become so minimal. So say if we get to New Zealand levels where they've had no cases in 2 weeks, it wouldn't make any sense to continue to have only 15 children in a class, because we haven't got enough teachers to make that equitable across all those bubbles. So they may do, if we have a really good track record with track, trace and isolate, plus zero surveys show that the virus is low in prevalence, not zero surveys, sort of swab surveys show that it's low in the community. Or it may be that in a region, so say Cheshire may have no cases for 2 weeks, and therefore in Cheshire you might be able to go back to normal operating hours. But it all depends on firstly knowing where the cases are, but also knowing where all the asymptomatics are, and that will only ever happen if we start swabbing people that don't have symptoms.
Julie's just put in the chat that Gavin Williamson's just said that all children will return to school in September. I don't know whether she means primary and secondary. But I think if that's the case, then we really need to start thinking about rotas, because clearly we can't do it at the moment with the numbers that we've got. So if all children go into access education, we need to start thinking about a rota system, because originally it was recommended we didn't have one. Ruth, anything coming up on the questions?
A couple of big questions about bubbles on a very similar vein. One is, what do we do if a child is ill in a bubble and a parent refuses to get the child tested? Do we carry on? Do we burst the bubble? Do we refuse to?
I didn't get that. What was it? And who refuses? There was something about refusal I didn't quite catch.
The parents refuse to get the child tested in a bubble. What do we do with that bubble then?
So it really does depend on how they're ill. So if it was me and I was that child's GP, then I would make an assessment to see how likely I felt it was to be COVID. If they've got tonsillitis and it's explained by tonsillitis, then not. But if the parent was refusing to get the child tested, certainly I wouldn't accept that child back. But I would be having conversations with the local public health, because there are this is a notifiable disease, so it is sanctionable if it's felt that you have a child with illness that you then refuse to participate in appropriate public health measures, and it would be negligent. Well, not negligent, but it would be a cause for concern if that parent then refused to get medical care if it was felt from the school that it was warranted. But you'd want to know why they're ill. Obviously, if they have a fever, you can get a fever, and we will get to the point where the highest cause for a fever in a child is not going to be COVID. I think we're sort of reaching that point, and well, I think we've passed that point, but we'll reach the point where we don't automatically jump to thinking it's COVID, because maybe they have appendicitis or something else. But if it's explained, then you don't need to do anything with the bubble, but you'd certainly want to have an answer for why that child was unwell in the absence of a test.
And if we suspect COVID, would you recommend that the whole bubble goes home and isolates until test results come back? Say a child did take a test.
So likewise, it really does depend on the likelihood of COVID in the first place. So if you're in a situation where you've had no cases locally, and that child hasn't been anywhere and they haven't seen anyone in the last 2 weeks from outside their sort of usual class sort of bubble or whatever, then obviously the risk is very low, and you probably wouldn't want to then close down the entire bubble, particularly if maybe it was a single isolated low-grade temperature that then petered away, because we know that kids have much variable temperatures. Say if they go out in the sun and they exercise, you can push your kids' temperature up to 37, 8, just by them running around and not cooling down adequately. So certainly you'd want to be, it's your pre-test probability that you want to be thinking about. How likely is it that in the absence of because it then goes back to, if you're very likely, if you think back to my first Coronacast, if you're certain that someone has COVID, so they've got their mum had it 7 days ago, they've now got a dry cough and a fever. If they get a negative test, you're still not going to want to open the bubble, because you're pretty certain that they've had it. And so it really does depend on whether you think it's likely or not, and that will be led by the local public health departments and that person's GP.
Okay.
There's just a question around.
Ruth, can this be the last one, because Matt's at work and he's wanted 40 minutes today.
Pregnant staff, BAME, what's the evidence telling us? And people who've got vulnerable partners at home, what's the evidence telling us about whether they should return there to work themselves and for the children?
Yeah, so coming back to, we know that BAME are at higher risk, but if you're in a very low risk group and you have a slightly higher risk, so say if black and minority ethnic, which it looks like they have a twofold rate of getting severe disease, but your absolute risk of getting severe disease is say 1 in 1,000, then that just puts it up to 2 in 1,000. You need to understand, so not things in isolation. So pregnant people, there is advice about them not being exposed to infections, just because we know that pregnant people are more likely to pick up infections, and also because we haven't had COVID for the whole length of someone's pregnancy, because it's not been around for 9 months. We are never certain whether it has implications at the earlier stages of pregnancy. So we just, to be cautious with all of this thing, we say pregnant women should avoid any form of risk setting. I think someone was telling me that the Department for Education has given advice about pregnant staff, and they should continue to. Yeah. Okay.
They have.
And then what was the second part of the question?
It was just what would the evidence be for those children of members of staff who have those issues? So, say for example,
zero evidence.
Okay.
Zero evidence, because we haven't had schools in this country in a higher prevalence state open, but certainly from the schools that have or that continue to be open, there haven't been sort of any concerns that children have provided a vector for shielded people. Obviously, shielded parents may opt not to send their kid to school, which is rightly so. That's their decision. But I think the evidence that we've now getting for different categories that we have traditionally deemed as high risk, we are now rethinking. So one of the questions was around mild asthma. I mean, my colleague that I worked with on a COVID assessment unit for 2 months had mild asthma and was seeing patients with COVID. Another colleague of mine is very overweight and continued to see patients in a high prevalence area where the whole ward was full of patients with COVID. So you've always got to bear in mind you're in a setting whereby what you need to focus on in schools is having a single case that you don't recognise that then could spread it. You're not in a situation whereby coronavirus is going to be really prevalent in the environment and nearly everyone's got it. That's not going to happen. What's going to be apparent in schools is that you may get a pupil that gets unwell midway through the day, and that's what you need to be focused on and act on. Or you may get a case in a family member and then taking that child out of school for 2 weeks. But you're not in a high prevalence area where you're worried that in so much. Obviously you want to continue to take measures like hand washing and things like that, because that's all about if you did have a case or if there was an asymptomatic, stopping it spreading. But also what you want to try and focus on is local outbreak control and data and what's happening locally would be key to that.
Great. Matt, one final comment from me before you go back to work. Thanks so much for giving us your time in the middle of your working day. It's really helpful having some of your expertise. 2 weeks ago, I said, Matt, do you think it's a time for schools to start gradually reopening to their pupils? Has anything changed in the last 2 weeks? Any advice you want to say about that in light of the current evidence we have?
Certainly not that there's nothing that's changed on the evidence front. Only that we continue to see a lower prevalence of coronavirus in society. I can only really answer that, Simon, by sort of if you give it another week, because it will take 48 hours to analyse any data from schools sort of reopening. But certainly from the schools reopening locally, it's all been very positive. So very positive from teachers. So as I said when we first spoke on that Coronacast, you're in the same position as we were in the sort of psychological sense of going into the unknown. But as time goes by, the unknowns are becoming fewer, and certainly there doesn't appear to be any great impact on the fairly limited reopening of the 3 years that we've seen nationally. But to fully answer that, it would be a conversation on the 14th, 15th, 16th of this month, once they've analysed any effect of reopening.
That's really helpful. Thanks so much for your time. Thanks, everybody. We've had nearly 300 on the call again. So really difficult decisions to be made, and they can only be made at an individual school level. I've just come off a call with Northwest exec members for the NHT, and most local authorities are saying to the teachers, the head teachers, the governors, it's really up to you in terms of your own risk assessment. So it's just really hard. It's one of the most difficult decisions I've had to make as a school leader, but we're there as a community to support each other, and there's no right and wrong decisions you can make at the moment. You've just got to make a decision what's right for your community. So thanks, everybody. We'll hopefully see you again in Coronacast soon. And thank you, Ruth, for doing the questions for us. And thanks, Dan, for hosting. And thanks again, Dr. Matt Butler. Thank you very much.
Thanks, Simon. Speak to you soon.
Take care, Matt. Bye now. Bye.
Bye.
Hey, thank you, everybody. Thanks, Simon. I'll end this call.
Bye.
Cheers, Dan.